Hello. In this short lecture, I'd like to cover some aspects of delirium detection, mainly focused on clinical practice. I'd like to start by asking you to read this. And this and many other experiences recorded by people who've had delirium show us the importance of recognizing this condition, detecting it, and putting into practice for each patient specific means of helping them recover as well as relieving their distress. I'll start by covering the definition of delirium along with some issues around terminology, an overview of the types of delirium assessment tools, the important distinction in clinical practice between episodic tools versus monitoring tools, some comments on the importance of doing a post-diagnosis assessment of the features of delirium, and then I'll give some conclusions. I'm going to start with a quick discussion about the DSM-5 criteria, which are there in simplified form. I'd just like to draw your attention to criterion C. Now, this is a bit of a problem in the sense that we know from lots of different research and also from common sense that if you have a significant disturbance in your attention or level of arousal, then they're always going to have disturbance in cognition. So although it's good to demonstrate that for lots of different reasons, actually it's always going to be present if A is present. And in fact, if you break this down, to demonstrate that somebody has delirium, at least in pragmatic clinical situations, it's really just these two aspects, a disturbance in attention and awareness. And by awareness, I think you might say ability to respond to the environment, including somebody who's not speaking in response to a question and so on. And of course, acute onset or fluctuation. These are really the key diagnostic features because, as I said, if A is present, then they're always going to get cognitive impairment alongside that. And the criterion D around causation, it's kind of implied that there is going to be some sort of medical cause. I'd like to also talk about the issue of low arousal states, because this is an important message from the DSM-5 delirium guidance notes, stating that even if somebody is unable to speak, is unable to, for example, do a cognitive test, that doesn't mean that they're untestable. It actually indicates that they have severe inattention, unless of course they fulfill criteria for coma. And this is really important in terms of a delirium detection process that isn't going to fall prey to the UTA classification. One of the major factors that's held us back in advancing delirium care over the years has been what Ken Rockwood called terminological chaos. And you can see in this slide some of the many different terms that have been used and are being used to describe what is essentially the delirium syndrome. So one very important thing we can do from now on is just all agree that we use the term delirium rather than these other terms. To address this problem in the field, a group of scientists and clinicians came together to agree on what would be the preferred definitions and preferred terms in the field. And these are shown in this slide here. So the term delirium refers to the clinical syndrome, as does coma, although coma is obviously where the level of arousal is very low compared with delirium. And the term acute encephalopathy is not the clinical syndrome, but it's the pathobiological process leading to delirium coma that's happening in the brain. The group also made the recommendations that the terms on the right, that is altered mental status, acute confusional state, acute brain dysfunction, and acute brain failure should not be used. And you can see more details of this in the reference there. A related paper which also attempted to address the problem, took these terms of delirium and acute encephalopathy and combined them into this third term of delirium disorder, which is mainly intended for research use. But this gets at the idea that we have this condition which combines a clinical syndrome that you see at the bedside with an underlying brain disorder. And we really need to be studying the clinical syndrome in relation to the brain disorder to make progress. These are some unpublished data which I'm presenting to show the value of using the word delirium consistently. The context is that over the last 5 to 10 years in particular, there's been a concerted campaign across the whole of Scotland to educate the workforce about delirium and also to encourage use of the term delirium. And the data on this slide are from publicly available databases showing hospital administrative coding of delirium, and you can see that there are large increases over the last few years, particularly in older age groups. This likely reflects increased overall levels of detection of delirium, but also reflects increased use of the term delirium in case notes. So although we're not there yet, and we still have a long way to go with respect to full ascertainment of all delirium, these data do show the value of using the word delirium consistently and provide some encouragement. So I've covered the DSM-5 criteria and some of the issues around proper use of terminology. This definition here is a pragmatic one that can be applied to clinical practice and can be used in teaching and so on, which essentially suggests that delirium is a rapid deterioration of mental functioning, and by rapid I mean hours to days, which is generally triggered by any number of acute illnesses, injuries such as hip fractures, drugs, surgery, and so on. This definition was pointed out to me by somebody in a Q&A session in a lecture once, and I really like it because it gets to the essence of what delirium is, which is that it's a change in the patient. And this is something, a concept that can be used in clinical teaching and in day-to-day practice very effectively. Just always to be on the lookout for a change in the patient, or to look for evidence of a change in the patient in the information you've got from the letter from the general practitioner or from a family member that's telling you what's happening to their loved one. Now, the amount of delirium assessment tools is amazing. In the blog that I wrote recently on this, I found 60 different tools, and these are covering all sorts of different roles, but actually most of them are not suitable for clinical use because they are too long and too detailed. And the ones in blue at the top are the ones that we really need to think about in clinical practice. One of the major challenges in the field of delirium is effective detection of delirium at scale. And we actually have a lack of information from studies or other sources about how tools perform in the real world. This is very important because validation studies alone don't give enough information. This is because validation studies have usually used trained researchers who, as part of the very nature of doing research, have more time to do the tool with each patient. And also, many of the studies have exclusions, such as excluding people who can't speak and so on. So it doesn't really reflect the real-world situation where you have to assess every patient, including the ones who are perhaps unable to speak. And also, often, such tools are done under extreme time pressure. So we really need to, as a field, do more on understanding how tools are performing in the real world, perhaps by looking at these two metrics, completion rates in a whole hospital and a whole population, and also what are the delirium positive rates for the tools that are being used. Before I go into discussing these, I'd just like to say that again, if we're focusing on clinical practice, we have to think about what is going to work, what somebody who isn't a delirium specialist, somebody who doesn't have a lot of time, is going to need from a tool in order to use it and to effectively detect delirium. So these are some of the criteria that you might consider. The tool obviously has to be quite short. Anyone who's encountering delirium who's got a responsibility to detect it should be able to use the tool. I think that the requirement that people have special training on tools isn't practical, because certainly in most hospitals there's often rotation of staff, doctors and nurses and others, and it's just not practical to provide half a day of training for them on each time they move just to use a tool. Another really important thing is that any tool that we are employing must be usable in patients who are unable to produce speech, and that's common. In fact, even this morning I saw 2 patients who were with delirium who were unable to produce speech, unable to even say their name. So the tool has to be able to pick that up as delirium and not lead to the tester just saying the patient is unable to assess. So let's consider 2 types of scenarios in which delirium is common and where it's very important that we have a system in place to pick it up. So scenario A is the emergency department or transitions of care, or at other times when delirium is suspected. So as an example, an 86-year-old man who arrives in the ED with pneumonia, and he's arrived via ambulance, family members not present, and there may not be an informant history there. So what tool or process should be used to tell if this man has delirium? So now let's move to a different type of scenario, scenario B, which is monitoring for new delirium in inpatients who don't already have delirium. And as an example, we have a 90-year-old woman who has sepsis and acute kidney injury, and she's obviously at high risk of new onset delirium, so we need some sort of process to tell if she's going to develop it after admission. These 2 scenarios are different in the sense that the first is maybe when you've met the patient for the first time, where you need to know quickly if they have delirium and where the information may be not complete and so on. And the second is when the patient might be in hospital for an extended period of time and you need to monitor new onset of delirium. So I would call this episodic testing, process 1, and monitoring, process 2. So with respect to process 1, this, as I said, is when somebody has arrived in the ED or in transitions or when delirium is suspected. Such a test would need a good balance of sensitivity and specificity, and I think needs to be close to providing a diagnosis, although with the caveat that I think there is no such thing as a diagnostic test in clinical practice. It's always a clinical decision. Process 2 is really different because you have to repeatedly administer the test or process, and that means that repeating cognitive tests like months of the year backwards isn't going to work, because it's going to be too high a burden for the staff and the patients. And if many of the patients don't develop delirium at all, then the burden on them having these tests maybe several times a day is just simply too high, as well as the practice effects. Such a test, I think, does need to be sensitive, and I think in general has to be observational rather than involving a long kind of interview type or cognitive test type process. Also, I think if it's positive, it would then need to lead to some kind of test or process whereby a more detailed assessment is done to determine if somebody has delirium. And this could be an episodic test with good sensitivity and specificity, or a clinician diagnosis. So if we look at these 2 processes and what is being used in clinical practice, first, considering the episodic tools, we have the confusion assessment method and the various versions of this that have been developed, some of which are listed there, the 4ET, which I'm going to describe soon, And I'm not aware of many others that are being widely used in clinical practice as episodic tools, but I'd be happy to hear about them, in the Q&A later. I'd also like to mention at this stage that ultra brief cognitive tests which have emerged. Some of these are based on interview questions like the squeak, or cognitive tests like the UB2, individual cognitive tests like months backwards. And these are kind of episodic because they can't be repeated 3 times a day, as I say, because of burden on the patients, but they could be used as an episodic test, which if positive then lead to a more detailed test. What about monitoring tools? Now, there are many of these, some of which have validation data, which I'll come to. I've listed the ones that I'm aware are being used in clinical practice on the screen there. I'd just like to mention quickly the CAM, which is used as an episodic tool, of course, with the preceding cognitive test and interview, which is recommended by the tool authors and which the validation studies are based on. But the CAM is also used, as I understand it, in some healthcare systems without a cognitive test or interview, maybe twice a day, 3 times a day, where just the features of the CAM are put on the screen and somebody scores them. And I'm not aware of validation studies for that variation of the CAM. My understanding is that the sensitivity might be quite low. So I'm not all that clear why that process is being used, given the absence of validation data. So I'd like to spend the next couple of slides introducing a test called the 4ET, which may not be well known to American audiences. So this was developed in my own hospital a few years back as a simple tool that could be used in clinical practice without special training. And it was based on the idea that this is what a clinician might do in a busy clinical setting, approaching the bed and trying to tell quickly if somebody had delirium or not. The 4A's stand for alertness, AMT4, attention, and acute onset. The first 3 items are done at the bedside. They take around a minute. So just a quick judgment on level of alertness based on the interaction, a 4-item orientation test, AMT4, an attention test, which is months backwards. And then there's another item which involves determining if there's been an acute onset or if there's fluctuation. Mostly this is clear from the contextual knowledge about the patient, but there are times, especially in people with dementia, where it's harder to tell. So the time that takes is variable, and that's the case for all tools that have this kind of item, and also DSM-5, that you sometimes have to dig to find out if there's an acute onset, but likewise you often do know fairly quickly from the history. And one of the design features of the 4AT was that it had to be robust to non-verbal patients, so that you can't get unable to assess with the 4AT. It doesn't require special training. And also, to make it clinically robust, there are multiple routes to a positive score. For example, if there's no informant, you can still score positive for delirium based on a combination of the other items in some situations. The 4AT is well validated now with a recent meta-analysis of 17 studies showing pooled sensitivity of 88% and specificity of 88%. The validation studies supporting the 4AT are comparable in volume to those supporting many of the other tests, as you can see in the left-hand side of the screen. We also did an RCT of around 700 patients comparing the 4AT and the CAM under similar conditions, and the 4AT showed higher sensitivity with similar specificity. We've also been quite keen to look at implementation, and these are some examples. So one example is that all hip fracture patients in the UK have to have a 4AT post-operatively to determine if they have delirium or not. And in more than 60,000 patients that are audited individually across the country, there's more than 90% completion and around a quarter are positive, which suggests that we're picking up about the right kind of level of delirium, although there's no gold standard assessment alongside that, of course. One American example is its use in Houston, Texas, where again, it's been used across a number of different hospitals with good completion rates and plausible looking positive rates. Locally, it's been introduced in the last 3 or 4 years, and between 2016 and 2019, using the electronic data records, we found that of 70,000 eligible patients, 51,000 completed the 4AT with reasonably good completion rates, especially in the older age groups. And again, with on the right hand side, that the scoring range 4 to 12 is indicative of possible delirium with plausible kind of rates for detection. So going back to a more general discussion now, if you're thinking about choosing an episodic tool, these are some of the factors that you might consider. So many systems can train their staff and use tools that require training and sustain that and have good performance, but not all systems have that. You have to think about what staff are going to be using the tool and are they in a position to use it effectively and well. Workflow is really important, so some tools might just be a little bit too long in very fast-paced situations such as the ED, and maybe there is a place for a two-stage process with an ultra-brief test, like for example the delirium triage screen that was developed in Vanderbilt by Jin Han et al, and then a more definitive tool. It all depends on your setting and your workflow, as does what kind of duration of test is going to work there. I think also we need to be honest about performance. We've certainly seen in some settings that tools that have been implemented and even used aren't picking up the kind of expected levels of delirium, and in other cases the tool is too awkward to use and people don't use it. So it's not just got to be something that looks like it might work, you have to test it and look at performance. Now I'd like to turn to monitoring tools. These are done on inpatients and can be done one or more times per day. And generally the model is that if they're positive, they need an episodic tool or a clinical diagnosis. Although some of the tools like the New Desk and the DOS aren't used in that way, and when they get a positive score, they're just considered to indicate delirium and then have clinical confirmation. Validation data is available for some of the tools, as I show on the left side of the screen. Tools that are widely used in some countries but not yet validated include News2, which I'll come to, the single question delirium, the SQUID, and this, as I say, this variation of the CAM used without the recommended cognitive test and interview before it's scored each time. That, to my knowledge, has not been validated for use in clinical practice. So I think that although this is now widely done, monitoring using all sorts of different methods, it does remain a really difficult area. From what I've seen of the published data, the sensitivity of most processes in wide clinical use is often low, not in all settings, but in many. So we really need to study the implementation and look at performance. And again, I'd just like to reiterate, I don't think that recommending ultra-brief tools to be done 2 or 3 times a day based on cognitive tests or interview is going to work, because staff and patients generally reject it because of the burden. So this is an example of a monitoring tool which is based on the magnificently acronymed SQUID, single question delirium. This is taken from a Scottish hospital, just a scan of a piece of paperwork. And essentially this was introduced without validation data for its use in this particular way as a monitoring tool, that the nurses are asked to, at the end of every day, just once a day, answer the question, is your patient more confused or drowsy than normal? And if it's positive, then this is then given to somebody who's responsible for doing an episodic tool such as the 4AT to see if there is delirium present or not. This is guidance that was issued by the Royal College of Physicians in England, and they base their advice on the SQUID, but tying it to the National Early Warning Score version 2, which was introduced about 3 years ago, and it has the alert, confusion, and then responsiveness to verbal, painful stimuli, or unresponsive as you. And this urges that if there's new confusion, or if somebody's in the V or P state, that they undergo a 4ET to determine if they have delirium. This is an excellent idea, and it's certainly got a lot of promise because it builds in observation of conscious level and possible new confusion to the nursing observations process. But at the moment, to my knowledge, there isn't any validation study for this, and it's something that needs to be done. But it's just to give an example of one hopefully fairly low burden monitoring process, but it does need to be checked out properly. So something that's really important is that once somebody has a diagnosis of delirium, the assessment shouldn't stop there. I think it's really important to assess and document the features of that person's delirium. Now, these are some of the features that you might consider. You might consider the level of cognitive impairment, how drowsy or hyperactive they are, their mood, and also the presence of psychotic features. I was very struck by this quote when I read it a few years ago, because it reflected my own observations that people with delirium are often suffering, they're distressed, they feel bad. So reducing the assessment of delirium simply to a tool which just looks essentially at cognition and level of arousal as well as onset isn't enough. And I think that you need to go beyond and determine if the patient's distressed, because that will then influence what your treatment plan is like. For example, if somebody's very distressed, you might find a way to bring a family member in or do something else to reduce that level of distress. So just to expand on this a little bit more, once you've looked for distress and picked it up if it's present, it's very useful clinically, because then you can specifically look for causes which can be remedied, like pain. Often people with delirium can't articulate their pain, so you might be able to find it through other means, by facial expression or by gentle movement of the potentially affected site of the pain, such as after a hip fracture. And then you can do specific things to relieve that distress. Alongside it as well, even if you have determined the cause, sometimes the treatment doesn't work right away and the distress remains. So relieving the distress itself is important through reassurance by yourself, family involvement, as I mentioned before, one-to-one nursing, and sometimes in a small number of cases, use of antipsychotic drugs, for example, for psychotic elements of delirium, can be justified. So in conclusion, I'd just like to re-emphasize the importance of using the word delirium rather than some of the many alternatives. This is really important for good communication with other healthcare workers, but also patients and families. With respect to choice of tools, it's really important not just to look at validation studies, but also to look at any implementation data that are available, and also, if you are already using tools, to check how much the tool is being used, and also is it detecting the appropriate amount of delirium. I've drawn the distinction between episodic tools, that's tools that you might use at the front door in the ED, for example, versus tools that you would use to monitor for new delirium in inpatients. And these are different kinds of tools because of the different demands placed on staff and patients. I've also said that after detection of delirium, that it's important not to just stop there, but to assess the features of the delirium in each case. And this is particularly important with respect to distress, because diagnosing delirium alone will not mean that you automatically pick up distress. So you should look for it and then find ways of relieving it if possible. And finally, if you're interested in reading more about some of these topics, I've written some blogs at the URL on this slide there. Thank you very much for listening.